It gives me a great pleasure to introduce my colleague and their friend, Dr. Hamad AlHameli, who's allergy consultant in Cleveland Clinic, Abu Dhabi, who's going to talk about the diagnostic of patients with suspected respiratory allergies. Dr. Hamad, the floor is yours.
Just need to have the water here. So can I close this one here? So are we talking about the diagnostic in vivo and vitro of patients with suspected respiratory allergies? I started this presentation yesterday, and it was inspired with some of the talk that we had in the WhatsApp group regarding the different allergy testing. So allergy diseases are amongst the most prevalent diseases worldwide, and as Dr. Ravi has just mentioned earlier, that it has a great burden which increase and it affects the quality of life. So it's very important that we make the diagnosis and also to confirm the allergen sensitization. I'm here mentioning that allergen sensitization goes like an allergy testing, which is positive, does not mean that you have allergy. It has to be coupled with the history. Oops. So the allergic diseases that we know, the allergic asthma, rhinitis, conjunctivitis, food allergy, drug allergy, venom allergy, and latex allergy. So remember, diagnostic workup for IgE-mediated allergic reaction diseases starts with the history. So history is the cornerstone of allergy diagnostic. So without history, then you cannot interpret the result of allergy testing. So there are several types of skin tests and are used in allergy diagnostic. So I'll start with talking about the skin prick test, which is presents the first level of approach for diagnosing of type 1 immediate allergic reaction or IgE-mediated allergy. It is safe. It has high sensitivity and good specificity when performed and interpreted correctly. So this is very important. Intradermal testing. I think maybe some of you wonder why I put intradermal testing in this presentation. Intradermal testing, it's been used for like a lot of it's to evaluate immediate IgE-mediated allergy and delayed type of hypersensitivity. It has been used for like diagnosing drug allergy and also for mainly for drug allergy and venom allergy. In the aeroallergen, for like the inhalant, this is like in Europe, it's not recommended to do it, and actually we don't do it. It's not a typical thing that we do it, but our colleague in the US, they use the intradermal testing for aeroallergen. But again, this is not like verified or approved by the IACI. So the skin prick testing, it is like a simple test. It assesses the presence of IgE sensitization in human when specific allergen is introduced through lancet into the skin of allergic individual. Dermal mast cell began to degranulate, mainly due to cross-linkage of allergen-specific IgE bound to the membrane receptors, and then the degranulation lead to immediate release of histamine and other mediator, inducing cutaneous response. Clinically characterized by wheal or like an urticaria, and surrounded by erythema, which is the flare. We only measure the wheal, we don't measure the erythema. So then comes the question, when do we do this skin prick testing? So only we do it if there is clinical information suggests there is type 1 allergy, like immediate type allergy. Skin prick tests are indicated to detect the presence of specific IgE to relevant causative allergy. Usually, we need to know like what is the, for example, the common aero allergen on what we are testing for. We don't like test for everything. We just have to be, after doing the history, we test for the things that we suspect that might cause the allergy. So these are the clinical condition where the skin prick test indicated for asthma, allergic rhinitis, conjunctivitis, eczema, which is very common. There are a lot of parents with patient with atopic dermatitis, they will come and will ask for skin prick test. Usually we don't do it for patient with atopic dermatitis unless there is like a good history that might suggest a type 1 allergy. So for example, like a patient tell you that, oh, after eating this, the patient, he like suddenly, like in between 0 to 2 hours, he start to have worsening of the skin symptom, then we might do it. Suspected food allergy, venom allergy, like for example for wasp or like honeybees, suspected drug allergy, and in chronic urticaria, usually we don't do it. We rarely do it. So it is less common that we use skin prick test for these disorders such as eosinophilic esophagitis. I know now there is a lot of people talking about EUE because of the new therapy that is available. We rarely do it for eosinophilic gastroenteritis or allergic bronchopulmonary aspergillosis. So this is, I think, most of the allergists, they always have encountered these things that people will come and they say they have like symptoms of food intolerance. It is not indicated, or chronic urticaria in the absence of allergic feature, desire to lose weight. I have like a couple of patients who came to me in the clinic and they said like, I want to do an allergy test just to see what food are making me fat. So this is not indicated. Screening for allergic sensitization, usually we don't do like a proactive screening for allergy. If there is no history, then don't do it. There is no screening. What is the advantage? It's inexpensive, except in this country. There is no lower age limit, so you can do it at any age. More than one allergen can be tested at the same time. The results are immediately available. It only takes like 15 to 20 minutes maximum. It's minimally invasive. It is safe. It is generally more sensitive than immunocap and trust. It's reliable and it's convenient. And sometimes if like in the absence of the availability of the allergen, like in the blood test, and also the extract is not available, you can also do like a prick to prick. So basically you bring the thing that you want to test and do prick to prick. So it is easier. What are the contraindications? If a patient is taking these medications, so this is like a temporary contraindication if he's like on antihistamine, first generation or second generation, and on antidepressant, this is very important because a lot of patients won't tell you that they are taking antidepressant. Exactly yesterday, I had a patient who had like symptoms of allergic rhinitis, and when I did the skin prick test, it was negative. Even the control test was negative, and she was sure that she did not take any antihistamine, and then voluntarily she said, yeah, I'm taking antidepressant medication. So always ask about these things. So the equipment that you need, you just like need a positive control is very important, negative control, extract, and lancet. So these are the lancet that we use. And you need also like a documentation. You need to write the name of the patient and what are you testing exactly. So I'm not going to go over the technique, but the common error in the prick testing test is placed too close together, less than 2 centimeters, and overlapping reaction cannot be separated visually, inducing bleeding. Usual with the skin prick testing is very superficial. It shouldn't like cause skin bleeding. Insufficient penetration of the skin by puncture instrument, spreading of allergen solution during the test. I remember I had one patient who was coming from another allergy, like a physician who was doing like allergy testing, and he was using the same lancet for all the thing. So really, cross-contamination, you need to be very careful with it. So measuring and interpretation of the skin, again, like having a positive test does not mean that you have allergy. This is only mean that you have sensitization. I'm just like trying to emphasize on this point over and over again due to the conversation that we had in the WhatsApp yesterday group. So usually the immediate skin test induced response that reach the peak in 8 to 10 minutes. And for the histamine, 15 to 20 minutes for the allergen. A prick test with a response of at least 3 millimeters in diameter in a wheel size, not in the erythema or the flare. It is considered to be a proof of presence of cutaneous hypersensitivity, indicative of presence of specific IgE. So the presence again of allergic sensitization, it's a common finding occurring in 8 to 30% of the population when using local standard panel of air allergy. So false positive tests may be provoked by contamination, non-specific mast cell secreted in the extract, as well as dermatographism. So you need to be careful that the patient does not have dermatographism or like urticaria. So the most common cause of false negative is ingestion of drugs, as I said earlier, with antihistamine or antidepressant medication. So just remember, since the interpretation of skin tests can have significant impact of the daily life in terms of avoidance measure and therapy, the specialist must pay attention to different clinical aspects. Positive tests may occur in absence of clinical relevant symptoms, and it's called sensitization. Negative skin test result can miss the presence of IgE-mediated sensitization due to lack of major allergen in commercial extract. Negative skin prick test result in children do not exclude possibility of development allergic diseases in the future. So intradermal testing, I'm not going to go through it. As I said, like it is very useful test, but this is only in the United States that it is used for the inhalant inhalant allergy. But in Europe, we don't use it. I don't know, Dr. Stewart, in Canada, do you guys use it? Okay. Okay. So again, like this is like a comparison about between the intradermal testing and skin prick test. It's about the speed and the interpretation and discomfort, but usually we don't do it again. So I will skip with these things here, the intradermal testing. So when we have we also, whenever we have like the allergy testing and we are like really skeptical, then we can go proceed further with the challenge. For the food allergy, we do like oral food allergy, and can be like either double-blind placebo-controlled food challenge, or can be an open label. Since we are only talking about the respiratory aspect here, so I just included the nasal challenge. Nasal provocation can be potentially useful to identify different chronic rhinitis phenotype, including diagnosis and management of local allergic reaction, allergic rhinitis. Sometimes in the patient will have like allergic rhinitis, but it is only local, like in the nasal mucosa. And when you do the blood test, the skin prick test, or like even you do the specific IgE in the blood, will be negative. So this test will really assess. So there is already like a standardized extract for house dust mite, alternaria, and Olea europa, which is like the pollen from olive trees, and mixed grasses has been used to assess nasal reactivity to identify clinical relevant allergy. And the reason why we do this, in order like to do like a tailored immune therapy for the patient, then we need to go further with these things. So there is also available conjunctivital allergen provocation. So basically, it's the provocation, the use of different pollen extracts such as ragweed and grass pollen, or recombinant molecular allergy such as PETV1, which is like a component from the birch trees. And usually, like the patient are put like in a chamber where he have the exposure of these pollen, and then we do the challenge. Bronchial allergic allergen provocation. Usually this is really not widely used, but I've seen it like in the hospital where I used to work. We used to do it, but it was only for like a research only, because there is always a chance of like inducing severe asthma, and patient will have allergic reaction. So we need to, once we say the bronchial provocation, it is really different than the methacholine challenge. So methacholine challenge is used to diagnose the asthma, but this is here only to confirm the allergy to air allergy. So what about the allergy testing in In vitro test assess antigen-specific IgE by testing patient serum. Advantage to this method include the use of single venipuncture that is not affected by medication. This is very important when a patient already on medication and you cannot stop him, then you can do the blood test instead. In vitro testing can perform with patients with affected skin, such as dermatographism or have a very bad atopic dermatitis. It is also a safer option if the patient is at risk of anaphylaxis. From my experience, I did not see any patient who developed like anaphylactic reaction after skin prick test. This is really unlikely, I can't say it, but it is still it is considered as a risk. It's always like in the literature. So what are the type of allergy testing in vitro? We have the enzyme night immunoobservant assay, which is ELISA, which make use of antibodies or antigen linked to enzyme solution. I'm not going to through the details, but what is really important is the RAST. The RAST, usually a lot of physicians, they always talk about RAST, but usually like now, we don't use RAST that much. And most of the time, whenever they say RAST, they are relating to immune cap testing. Because the RAST has it, like, I haven't seen it like for like more than 10 years now. So this serological measurement of allergen-specific IgE antibodies provide clinician with a measure of patient allergic sensitization profile. There is two fundamental types of serological IgE antibodies assay performed in the clinical immunology laboratory. We have the singleplex, which is or the monoplex. Assay refer to a laboratory method that only used for one allergy. And then we have the multiplex. When we say the multiplex, it is like multiple allergy. It is different than the food or like aeroallergen panel. Because with the aeroallergen panel, you have like one test that has like multiple things. It's tested at the same time. And once it's positive, you don't know which one is positive. It's give you like an overall result. But with the multiplex, it gives you like specifically for each allergen. And now with the use of Isaac and Alexia, so we have like we can test of multiple allergen at the same time. So I think here this is like a table that show like the advantage and limitation of singleplex and multiplex. It is one of the most important things that is with the multiplex is like with the blood test. You need like a really a small amount that you can use. But when you do the singleplex for multiple allergens, then you need like more blood tests. And also it has like the performance, usually it is the same from the result wise, but also it has like important role in the cost saving, because when you do like the multiplex, it's using like a microarray chip, so you don't have to have all the reagent for all the single one that you have. So the last one in the vitro that I'm going to talk about is the basophil activation test. This has been used in vitro diagnostic test that demonstrate the function of IgE in its ability and its ability to induce effector cell activation following stimulation with allergy. Activation of basophil can be analyzed by measurement of mediator release such as histamine, or by change in plasma membrane marker such as CD63, which is the main thing that we measure. So far, I don't think that here in the country we have anyone who is doing basophil activation test. This is has been really established like in the food allergy, drug allergy, and insect. With the aeroallergen, still we don't have enough data, but it has been used. So what is the advantage of the basophil activation test? High specificity in diagnosis. The BAT in food and venom allergy is a good example where they have a high specificity, safety, that is safe for the patient, as it does not require any in-vivo exposure to the allergen. Variety stimulation, almost any material can be tested as long as standardized conditions are used. What is the limitation? The limitation of this test, that we need like almost like a fresh sample. We cannot use any blood that is more than 48 hours. It always has to be within the 24 hours. There is a patient like 10 to 15% of these patients are non-responder. They don't release basophils. And still it is a manual assay required, so automated assay are desired and could be done in the future, but for the time being it's done manually. And also subjective data analysis. Interpretation of flow cytometry basophil activation is subjective. Attempt to standardize and automate its using by using the artificial intelligence are underway. We still don't have it. So that's about the allergy diagnostic. This is an allergy study that I conducted in SKMC. We have done allergy testing on the pediatric population. So the type of study, prospective study, and it's done in the outpatient clinic in the period from the 1st of January 2018 to 30th of December 2018. The population are Emirati pediatric, age between 6 to 16, having asthma, allergic rhinitis, or both. So we have tested 21 allergens. At that time, those are the most common allergens that we've seen. So we only tested for 21 allergens, and this was the research checklist. So patients have to have symptom of allergic rhinitis or asthma or both to be included. So the allergens were tested were grass, plant, house dust mite, mold, animal allergen. Total number of patients were 65, because we have to exclude a lot of patients, especially patients who have syndromes or congenital abnormalities or oxygen dependent. So these are the allergens which were tested from the grass, house dust mite. What is really interesting, I want to test the Volumia tropicalis, because it hasn't been really described here, and I was surprised. And mold, these are the only mold that we tested here. We did not test for everything. And animal allergen, we did the house dust, we did the cockroaches, and also cat and dogs. So basically the gender, like 57% were female and 43% were male. The median of age was 9. Most of our patients came from Abu Dhabi. 53 of the patients came from Abu Dhabi, 1 from Dubai, 3 from Sharjah, and 4 from Ras Al Khaimah, and 4 from Fujairah. So this is based on the gender. So it was like almost like similar with patients with asthma, similar number of patients, but with the allergic rhinitis, it was more common in the female than the male. And both, it was almost similar, but it was higher in the female. So this is with the relationship between age and number of allergy. So if you can see here, like the older the patient he is, then the more allergen he will have. So these are the allergy that we found. We found that 30% of the patient have 30 patients have almost 64 patients, they have like both house dust mite. Volumia tropicalis, there was 19 patients who have Volumia tropicalis. So, and then the third common one, it was from the mold. The most common one was the alternaria, and from the grasses, pigweed was the most common allergy. From animal, cat was very common. So 29 patients out of like 65, they had cat allergy. So we didn't stop here. We did something different. We start to take the addresses of the patient. So I know this is not clear, so I will put it here on the map. So we start to ask the patient where are their addresses, where do they live? And we start to plot these allergens based on the area where do they live. And it's very interesting. Al-Falah, the new Al-Falah area, it's a new area. It's in the middle of the desert. It's a new community. Surprisingly, with the allergy, with the allergen that we tested, 100% of these patients have German cockroaches allergy. And when you look at the house dust mite, let me see here, house dust mite around 40%. So there is higher with cockroaches. And when I ask the people over there, there is like really heavy infestation of cockroaches in this area, although it's a new area. What about, and Al-Falah area, it's mainly like populated by like local people. So what about Mohammed bin Zayed? So Mohammed bin Zayed also, like, it's very common that they have local population, and most of the people there, they plant palm trees. As you can see, 50% of the population have allergy to palm trees. Sensitization again. But again, the house dust mite, it was the second, also like as common as the date palm. Cockroaches was, you can see here, like around 15% have the American cockroaches, and around 25% have the German cockroaches. So this was Mohammed bin Zayed. What about Banias? The Banias is like one of the oldest community that was like out in the outskirts of Abu Dhabi. If you can see here, 100% of these patients have Aspergillus. Yes. So 100% here. But if you look here, like with the palm trees, there was 0. And I went there to Banias, and there wasn't a lot of palm trees over there, which I was surprised. Again, cat allergy is very common. So 100%, 25% of the patient, they have bulimia tropicalis. This is Khalifa city. Again, it's highly populated by local people, mainly, like most of the population there are local. 50% they have date palm allergy, which is the second one is bulimia tropicalis. Again, what about al-murur al-shamkha? Al-shamkha also, it is in this, like in the outside of the city. The most common one was, I cannot really see, 33% was pigweed, was the most common one, followed by house dust mite and American cockroaches. American cockroaches is more, 16%. What about al-murur area? So al-murur area, the most common one was 20, which penicillium mold was the most common by 20%, followed by I cannot really see it. Penicillium was the most common one, and then American, again, 12% with the cockroaches, 17% was with the Frankfurt colors. House of Font. And Alternaria, 17% have Alternaria. So this is here is the most common allergen in each of these districts. In Al-Shamkha, 33% have house dust mite. In Al-Murur area, it was penicillin. In Khalifa, it was 50-50, was like tie between date palm and the Bulimia tropicalis. In Banias area, it was 100% Aspergillus and 50% was pigweed. Mohammed bin Zayed was 50-50%. They were a tie with date palm and pigweed. And the blue one, it was the penicillium again. Al-Falah area, 100% of the patient from this area were with German cockroaches. So there is a variation. Like as Dr. Muhammad said, like when we do the allergy testing and we see the result, we can always tell like where this patient is coming from. So for example, when you look at the patient who's coming from an ain, you will find that you have a lot of grasses, a lot of plants, but really rarely you will see like house dust mite. House dust mite almost does not exist in an ain. But in Abu Dhabi, on the other side, you'll find like more house dust mite, more animal, and the grasses and the plants is less than the house dust mite. And the Northern Emirate is like more like mix of both pictures. So that's it.